It's my pleasure to call the next speaker, Dr. Sunir Garg. He'll be talking to us on recent advances in the prevention and treatment of endophthalmitis.
Hi, thank you, Dr. Lee and Dr. Sharma for inviting me to this excellent symposium. I always learn a lot from everybody on this panel. I have no relevant financial disclosures. We'll talk about 4 different topics. One will be that masks and no talking are associated with less endophthalmitis. Prefilled syringes are associated with less post-intravitreal injection endophthalmitis. Routine use of topical antibiotics for intravitreal injections are at best useless. And aqueous chlorhexidine may be a useful alternative in some eyes who are not very tolerant to povidone and iodine. So the outcomes of post-intravitreal injection endophthalmitis are worse than outcomes after other intraocular endophthalmitis cases, mostly because there's a much higher incidence of oral flora, about 3 times more. And if you end up with oral flora-associated endophthalmitis, your vision is going to be hand motion or worse. And we know that the oral flora comes from bacterial dispersion by somebody in the room, whether it's the doctor, the assistant, or the patient, I can't tell you for sure. And we know that reducing bacterial dispersion, either by wearing a mask or by reducing the amount of speaking in the room, reduces endophthalmitis, particularly that from oral flora. But what we were wondering was, well, we know that not talking is helpful, but does the preparation of the drug matter? We've all gotten used to conventional preparation of drug where you pop a vial, but recently ranibizumab became available in a prefilled syringe. It became available in Japan about 5 years ago and in the US about 3 years ago. So we conducted a 10-center retrospective study comparing conventional preparation with prefilled syringe in the US and Japan. And what we found that during the study period, we did 165,000 conventional injections with a suspected endophthalmitis rate, meaning any eye that you were worried enough about to do a tap and inject of about 1 in 3,800, compared to about 78,000 injections with a prefilled syringe, and our suspected endophthalmitis rate was 1 in 6,500, a trend towards significance but didn't meet it. But the culture-positive results were more impressive. We had 1 in 7,500 culture-positive cases in the traditional group, but only 1 in 39,000 in the prefilled syringe group. That was significant. Although the numbers are small, another impressive finding from this is about a quarter of the conventional group, when they developed endophthalmitis, it was from oral flora, whereas none of the 2 cases in the prefilled syringe group developed oral flora-associated endophthalmitis. And that impacted visual acuity. If you were in the conventional group and you developed endophthalmitis, on average you lost about 4 lines of vision, and about 25% of people would end up count fingers or worse. Versus if you were in the prefilled syringe group, you really didn't lose much vision, and nobody ended up with a devastating outcome, and that's mostly driven by the presence of oral flora. And if you look at this video, you can appreciate why. On the left is the prefilled syringe. It's pretty simple. You pop open a pack, you take out the needle, you take out a 30-gauge syringe, you link the 2 together, and you're done. But in the traditional method, you're taking out a vial, you're popping the lid, you're putting a filter needle on the syringe, you're drawing up the drug, you're taking off the filter needle, putting on a 30-gauge needle. It takes longer, there's more steps, more possibility for contamination. Aflibercept will now be available in a prefilled syringe around the first of the year, and hopefully that'll be the standard of care going forward. So the take-home message from this is that masks or a no-talking policy are associated with reduced incidence of endophthalmitis, including that from oral flora, and prefilled syringes also appear to decrease the incidence of endophthalmitis, potentially including oral flora. Topical antibiotics are at best unnecessary for intravitreal injection. There was a study from the DRCR network a few years ago found they didn't help. We did a larger retrospective series, and in our series we found that not only wasn't it helpful, but the routine use of topical antibiotics was associated with an increased susceptibility towards developing endophthalmitis or an increased risk of endophthalmitis. It did not improve visual acuity outcomes, and it bred resistance. The only thing that really has been shown here to date to be useful in preventing endophthalmitis is povidone iodine 5%. Interestingly, still, even with copious amounts of povidone iodine, a quarter of eyes will have preoperative or will have culture positive immediately after installation. The benefits of it is it's cheap and you can pretty much get it anywhere, but some patients hate it. So much so that it can be a big barrier for them to come in for repeat injections. They don't hate the injections so much as they hate the way they'll feel from the povidone iodine. Another thing we can consider using is chlorhexidine. When we're scrubbing, sometimes we'll pull a betadine brush, sometimes we'll pull our chlorhexidine brush, and that chlorhexidine brush is chlorhexidine gluconate. It's a broad-spectrum antiseptic, which works really well to kill bacteria, but if you read the package, it says not for eye use. Aqueous chlorhexidine is different than chlorhexidine gluconate. There's a study that came out of Australia about 3 years ago that looked at aqueous chlorhexidine as antisepsis for intravitreal injection. They did 40,000 injections. They only developed 3 endophthalmitis cases out of those 40,000, which is a really low rate. They thought maybe one patient had a suspected allergy, and they had noted that patients were perhaps more comfortable with aqueous chlorhexidine compared to the povidone iodine. There was another study that came out. They took 40 consecutive patients, gave 20 of them povidone iodine, 20 of them aqueous chlorhexidine, and wanted to find out if one group was more comfortable than the other. They found that their pain scores were higher with povidone iodine, meaning patients were generally more comfortable when they had aqueous chlorhexidine, and about 5% of the eyes in each group were culture positive. We did a slightly different study where we wanted to compare culture positive rates, the status of the corneal epithelium, as well as patient comfort using aqueous chlorhexidine 0.1% versus povidone iodine. We took 50 patients who were getting bilateral same-day injections. We randomized one eye to povidone iodine, and the other eye got aqueous chlorhexidine. Our primary outcome was a pain score using the Baker-Wong scale, both immediately after injection as well as the next day. Our secondary outcomes were looking at the status of the cornea using a fluorescein-based corneal grading system, which is the ocular surface score. We also looked at conjunctival culture results, both immediately before as well as shortly after installation of the antisepsis. And what we found was that patients had more pain when they used the povidone iodine right after the injection, but by day 1, there wasn't such a big difference. The majority of patients had no pain with either drop, but if they did have pain, about half the patients did, they almost always said that the eye that got povidone iodine was more painful than the eye that got aqueous chlorhexidine, and that was true immediately after injection as well as the next day. And part of that's related to what happened to the cornea. If you look at the ocular surface score, the eyes that got povidone iodine, which is the orange color, had a lot more epitheliopathy than eyes that had aqueous chlorhexidine. And here's a color photo that I think sums it up really well. The top picture is a person who got aqueous chlorhexidine. The cornea looks pretty good, but if you look at the bottom, the cornea is pretty beat up with a lot of epithelial changes. The culture positive rates were also pretty similar between the two groups. There was still a reasonable number of culture positive cases after installation of antisepsis in both groups, but chlorhexidine wasn't worse. So the take-home points here was that aqueous chlorhexidine may be better tolerated than povidone iodine in some patients. There seems to be similar efficacy in terms of reducing bacterial forming units, but there's been no randomized controlled trials which have compared the two. It's not the standard of care in the United States, and it's definitely more expensive. A big bottle of povidone iodine will cost you about $15. You have to get aqueous chlorhexidine from a compounding pharmacy in the U.S. A small 15 ml bottle costs $100. I've had a couple of patients who actually want to pay for that out of their own pocket because it helps them that much, but I don't know if that's useful for everybody just yet. So in summary, mass and no talking are associated with less endophthalmitis. Prefilled syringes are associated with less endophthalmitis, and I'm hopeful that all manufacturers will transition to that over time. Routine use of topical antibiotics for intravitreal injections are at best useless and are potentially harmful, and aqueous chlorhexidine may be a useful alternative in some eyes that are intolerant to povidone iodine. Thank you.
Are there any questions?
So, Dr. Garg, so do you have a routine protocol in terms of how you prepare before the anti-VEGF, before intravitreal injection?
Yeah, so we'll give patients a topical anesthetic, and then we'll make sure that we put the anesthetic when they're looking up, down, left, and right, then put in a drop of povidone iodine, wait maybe 30 seconds, put in a second drop, wait another 30 seconds to a minute, and do our injection. If we're doing a viscous lidocaine, the key thing to do is to make a sandwich. So you want to put the topical anesthetic on, then betadine, then a viscous lidocaine jelly if we're going to use that, then more betadine, and let that sit.
There is a veterinary preparation for chlorhexidine, and I think it occurs available through Amazon. Has anyone used it in humans, to your knowledge?
I haven't looked at aqueous chlorhexidine through Amazon, but it's something that we can look at. We have a big, strong Seattle presence here, so maybe you guys know more about that. In Canada, it's pretty widely available. In Australia, it's pretty widely available. In the U.S., it just happens to be compounded, but I'll check that out.
Great presentation, Dr. Garg. So the evidence is that a single drop of povidone iodine is equivalent to 3 days of thrice daily antibiotics. So if in some of these patients where povidone iodine is an irritant, can a 3 days, thrice daily dose be an alternative if chlorhexidine is not available?
Yeah, so it's a great question. We know that the cataract surgeons will traditionally start the topical antibiotics 3 days beforehand to reduce the bacterial surface load. The difference, though, is we're doing repeat injections, and patients will have dozens or maybe even over 100 of them. And what we found is that repeating the course of antibiotics over and over again tends to breed resistance. And so that's a big difference in what we do versus what the cataract surgeons do, which is as a one-off injection, it might be reasonable, but for ongoing care, I'm a little concerned about using that short course of topical antibiotics.
The injection, the Povidone iodine drop post-injection, that is irritant actually. The one that is instilled prior to the injection and again washed, that doesn't cause much of irritation. I think we can avoid the post-injection drops of Povidone iodine. That could be an alternative.
Yeah, it's an interesting question. Some people will put after, and I'll do this as well, after intravitreal injection, I'll put in another drop of Povidone iodine. There was a study out of the Retina Group of Washington which suggested that it might be helpful to people. I have no evidence to support this, but sometimes I'll irrigate the fornix of people after the injection to flush out the betadine, and a topical non-steroidal at the conclusion of the drop also helps to reduce pain.
Thanks for an excellent talk. Your comment about stopping talking before injections, what sort of time, is that at the exact time of injection or a minute before or,
Yeah, so we'll traditionally move patients to an injection room, and so I've completed my exam or discussion. I'll talk to them, and even when I'm talking to them, I tend to talk away from where the patient is sitting. And then, you give it a minute or two to let whatever bad things are floating around. The criticism I got from that idea was from Dr. Shackett, who said, you want patients to feel comfortable talking. For example, if I'm approaching the wrong eye, you want them to be able to say, stop. And that's where masks are probably a better option. But we just haven't gotten in the habit of doing that routinely. So minimizing talking can be useful adjunct.
Thank you.
Does the location matter, whether you give it in the superior temporal or inferior temporal? Do you change the quadrants as you do the needle? That's my first question. The second question is eye speculum. The patients just hate it. So I've been resorting to Desmarais retractor, so pulling the lower lid down and getting my assistant nurse to put the, pull the upper lid up with, with just fingers. And does the size matter? In Australia, we've only got 30 gauge needles, the smallest size, but I'm told in the US and in Japan, they've gone to 32, 34 gauge needle. Is it widely available here?
So first question, superior versus inferior location. In our study, it didn't seem to make a difference. So I don't care. I usually go inferior temporal just because my access is better. The last question, the gauge of needle. You can use whatever you want. There's no real standard in the U.S. I think most of us tend to use 30 gauge because it's widely available, it's not expensive, and it's fairly stiff. And then the second question.
The third one was the eye speculum. I've
Oh, yeah.
resorted to Desmarais.
So we gave up the speculum a long time ago, and what I've started doing is just manual lid retraction. And that seems to be more comfortable for the patients and does not change the endophthalmitis risk as far as we can tell.